Personally, to survive my childhood, I learned to doubt my own experiences, to maintain the adults in the light of caring individuals. It was safer to question my behaviours than theirs. I couldn't control them, but I could control myself. So I thought I must be wrong in thinking or doing such and such, since they said so. I used that same strategy when in a relationship with my abusive partner. The pattern of self-doubt carried on in my adulthood and still makes me more vulnerable to intimate partner violence. In my life, I've had more experiences of disempowerment than empowerment. So whenever the former shows up, it has more weight. It's a lifetime's work to shift the balance. For the cycle of abuse to stop, you have to have more positive relationships than abusive ones to create the new norm.
Domestic violence and abuse is a public mental health problem that has been marginalised for too long and needs to be addressed so that women, men and their children are not exposed to intimate partner violence. With coordinated action, scientific effort and political will, there is opportunity for change and also an imperative to do so. So I'm Professor Helen Fisher. I'm a Professor of Developmental Psychopathology based at King's College London in the UK.
Hi everyone, my name's Suzanne Jacob. I'm Chief Executive at a UK-wide domestic abuse charity called Safe Lives.
Hi, I'm Kelsey Hegarty and I'm from Melbourne, Australia, and I'm the Chair of Family Violence Prevention at the Safer Families Centre, which is across the Women's Hospital and the University of Melbourne.
Hi, I'm Surya Sidat. I'm a psychiatrist and researcher based at Stellenbosch University in Cape Town, South Africa.
Hi, I'm Helen Minnis from Glasgow, Scotland. I'm a child and adolescent psychiatrist, and my clinical and research focus for many years has been on the mental health problems that sometimes arise from abuse and neglect, including intimate partner violence.
Well, we know that the rates of experiencing and also perpetrating domestic abuse and wider forms of violence against women and girls are really endemic across all the different countries that we're going to be talking about today. We know that there are reports of severe and sustained mental health problems that go alongside those experiences of violence, abuse and exploitation. And that's across all of those groups. So adult victims, child and adolescent victims who are either living in the home or living with peer experiences, and also those who use abusive and exploitative behaviours are often experiencing quite significant mental health issues, which is not an excuse for the behaviour that they're using, but it is part of that correlating picture. And that can range from blood disorders, eating disorders, phobias, sleep disorders, depression, anxiety, self-harming, right across the range of mental health concerns. And we know that the impacts go on and on and on into future life, even after somebody is outside of their initial situation, that goes on into later life in a very severe way. So we know also that COVID has exaggerated the situation in many, many ways. People's usual coping mechanisms were stripped away, and the situation in many countries around COVID, the restrictions people lived under, were almost a mirror image of abusive situations in terms of the constraints that people were living under and the pressure that put on people's mental health. So there couldn't be a more important time to be raising these issues. So about 1 in 3 women will experience physical or sexual violence by a partner in their lifetime, or sexual violence by a non-partner. And obviously that's only the picture for adult women. We know that there's a lot of underreporting going on for younger women, for boys and adolescent men. And also that doesn't capture the figure around those who are using abusive behaviour. So the scale of this problem is absolutely huge. What we see in the UK at the moment, I think, is probably mirrored in other countries as well, is that there is a structural and systemic gap between the responses we currently try to provide around domestic abuse and wider violence against women and girls and the responses we provide to mental health. So we know there are pockets of really good practice going on in different parts of the UK, some really great practitioners who are really trying to make change on an individual level. But in this country, what we don't see yet is that kind of structural, systemic leadership to make change, to join up these different issues. And there's also a kind of really big element of this around health inequalities in the UK. There's been a lot of conversation over the last couple of years, particularly following Black Lives Matter, about the really significant gaps and problems in terms of the different health responses different groups get in our country and the unequal nature and inequitable nature of those responses. So, as I said, COVID has really exaggerated all of these situations as well. It means that people are really struggling to get in touch with any kind of health practitioner, never mind talk about very sensitive issues, make disclosures, and get the kind of support that they need. And often what we're finding is that means that specialist domestic abuse and wider violence against women and girls sector organisations are holding cases where there are some very severe mental health issues going on because they can't get their service users, their clients, into mental health responses. And that's not good for the service user, and it's not good for that practitioner either who's not equipped to do that. So we're seeing a lot of harm caused by that lack of availability and that lack of connection between the different services.
Being able to access my doctor via telehealth during COVID was a lifesaver for me because I've been housebound due to my mental health issues since March 2020. Of course, going in person is always much better when doctors are looking after your mental health, but that's not always possible. It took away a lot of the stress and anxiety, worrying if I could actually physically get there. My doctors were patient and sympathetic. Nothing was rushed. Also, I've been accessing my domestic violence counselor through telehealth every 2 weeks, and that really has been invaluable.
Similar to the UK, our mental health system needs reform because certainly some policies and some practitioners are talking about trauma in a way that would mean we could provide a more empathic, non-judgmental response to survivors. However, what we find is that trauma doesn't always address current domestic violence. So the practitioners think about it in terms of child abuse or particularly child sexual abuse, and they haven't been trained or equipped to deal with the issues when someone is in an ongoing relationship where they're really in fear most of the time, and the issues around safety are just not something that have been current safety are not something that practitioners have been taught about. And so that means that there's a lot of talk about trauma-informed care, but it's not trauma and violence-informed care. And it's not trauma and violence and gender-informed care. So there's not a gender lens that has been put on it. Now, I don't think this is specific to Australia. I think I can see that, it's probably in many high-income countries that this issue is happening. And I think that there's certainly in some sectors a willingness to reform, but generally I think the connection between the domestic violence services and the mental health services have been very siloed, as have alcohol and drug services. So, in the past there's been a movement here to join the two alcohol and drug services and the mental health services, and we need that same reform and movement so that it's a triple thing. They all go together, and as we've just heard, the idea that it's not a cause of perpetration, but certainly in all alcohol and drug and mental health services, we should be inquiring and responding appropriately to disclosures of domestic violence and abuse. And we're not in Australia at the moment. But so, hopefully, this commission is addressing that problem of needing mental health system reform.
In South Africa, as well as in the rest of Africa, there is a dire shortage of mental health specialists to meet the needs of both survivors and perpetrators of IPV, as well as survivors of other types of trauma. And while IPV is a global health problem of epidemic proportions, in South Africa, and this is mirrored in other African countries, we have substantially high rates of exposure to IPV. And in addition, we have what we refer to as a triple burden. We have this burden of IPV, HIV infection, and a wide range of mental health problems, especially common mental health disorders. And this triple burden makes women living in Africa, the epicenter of the HIV epidemic, all the more vulnerable to being exposed to IPV. And in fact, the data that we do have suggests that about 30% of women are affected by these three burdens concurrently. And so the need for intervention is essential. And there have been a few promising large-scale interventions which have taken place in South Africa and on the African continent. This includes interventions such as the Stepping Stones and Creating Futures intervention to reduce risk behaviors in male perpetrators, showing that these interventions result in a reduction in IPV. And there have been other interventions as well, including microfinancing interventions to empower women as a pathway to reducing IPV and then the risk of HIV. But there has been considerably less research done on interventions within healthcare settings. So most of these interventions have been implemented in community settings. And in addition, few interventions have included mental health screening or counseling, which is very problematic. And few interventions, even those that haven't focused on impacting mental health, have reported on mental health outcomes. And I'm aware of just one study that was conducted in a primary care setting where primary healthcare nurses were taught to screen for IPV. What that study showed was that, it had significant mental health benefits. It reduced alcohol abuse, it improved relationships, and also reduced self-injurious behavior among those women.
Well, I think we often forget about the child, actually. It was one of the things I really noticed and found really painful to listen to during the pandemic. Certainly on the UK news broadcasts, everyone was talking about domestic violence and could imagine it, but hardly anyone was talking about the effect on children. And of course, if you're cloistered, locked down with someone who is violent, the impact on children is even greater. So, if adults are living in fear, the children are going to be living in fear, and they're even more powerless to do anything about it. And we know that exposure to intimate partner violence is actually one of the worst things that can happen to a child. I don't really understand why this is, but it seems to be one of the most toxic forms of early adversity. So we know that children who've been exposed to intimate partner violence are at least twice as likely to develop persistent aggressive behaviour themselves. And that's such a loss of potential, because often it's children who actually have big, fearless personalities who, if they hadn't been exposed to that violence, may really thrive. But if they are exposed to that violence, things can go very badly wrong, and they can end up themselves being at much higher risk of being exposed themselves in adulthood, or being perpetrators themselves. So that whole intergenerational cycle is perpetuated unless we really remember about the children that are in the home.
So this Lancet Psychiatry Commission on Intimate Partner Violence and Mental Health was convened to consider progress in reducing the prevalence of intimate partner violence and associated mental health harms, and to establish a roadmap for strengthening responses across mental health services, research and policy. It was instigated by the Violence, Abuse and Mental Health Network, an interdisciplinary research network funded by UK Research and Innovation that aims to understand, prevent and reduce the impact of domestic violence and sexual violence on mental health. This commission brought together individuals from a variety of backgrounds with interests or expertise in intimate partner violence and/or mental health, some with lived experience of these issues and others with expertise from the work that they do. And this commission presents a synthesis of evidence. That's including academic, clinical, and experiential evidence, which was considered important by the authors, who were a group of international experts coming from a range of countries, including Australia, Canada, India, Malaysia, Peru, South Africa, Switzerland, the UK, and the USA. So in this sense, the Commission differs from a standard review of the literature that is usually carried out by a small number of people from the same group and often in the same university. So it really is broadening that out to a wide range of people across the world with different types of expertise. It's also different in the sense that it evaluates existing evidence on a topic from these multiple perspectives and really tries to set out an agenda or roadmap for change.
I wish mental health practitioners would stop judging us as survivors and see us for how strong and resilient and courageous we are. I fought the hardest to protect myself and my family from being murdered. And I should be seen as a hero for that, not pathologized by a mental health system that sees me as a problem and a victim.
In putting together this commission, we decided to focus mainly on the changes that are needed to address intimate partner violence within secondary mental health services. Although mental health care is delivered predominantly through primary care globally, the relationship between intimate partner violence and severe mental health problems and how best to address such violence within secondary mental health care has been severely neglected. And thus we felt this commission really needed to make this important focus on secondary mental health services. Unfortunately, this inevitably means that some of the recommendations of the Commission may be more relevant for countries who have widespread provision of mental health services. But we believe there is much in this Commission that has relevance for practitioners, policymakers, and non-governmental organisations across the globe. And we hope the recommendations presented will act as a starting point for people to consider how best to prevent and tackle intimate partner violence within their own contexts in order to break the cycle of intergenerational transmission of trauma and to reduce the global burden of mental health problems.
I would urge everyone to make use of the content of this commission, this evidence, and also the network of people who've put it together. I think there's something very, very strong about all of us across different nations, different countries, recognizing that we're all facing these same challenges and trying to link arms and make some change together, because there's a real need for institutional advocacy. We've been quite stuck, I think, for quite a long time, and frontline specialist services in the UK will recognize this picture, I think, of being quite stuck and really trying to make this difference. I would really encourage everybody to think around all members of the family, all people in the situation, both those who are using abusive behaviour and those who are experiencing it, and those who are experiencing it in all different age groups and all different situations. Might be inside the home, might for younger people be outside the home in their sort of early intimate peer relationships. I really would like people to match this up with the work they're doing around greater diversity and inclusion in frontline provision. As we've talked about in other parts of this conversation, some people are facing really, really exaggerated additional barriers to getting the help that they need, both mental health support and specialist response for the violence and abuse that they're experiencing. And that may be because of racism or historic discrimination. It might be because of their LGBT plus status. It might be because of their disability and all the kind of mythology that we know sits around disability in relationships. So would really encourage services to think about how we connect up the whole picture of what people are experiencing in order to take the action that we need. We've got some opportunities coming up in the UK. We are having yet another restructure of our headline health arrangements. So we're creating these things called integrated care systems, which is going to be an important change and also a moment for influencing. We've got a women's health strategy coming out and a women's health ambassador being appointed. So we've got those further opportunities. And, you know, as hard as it is, I would encourage services to keep prevailing upon their colleagues in the local area, whether that's mental health through statutory provision or through charitable provision, whether it's the police who are actually coming into contact a lot with people in mental health distress. We know that, you know, working with those different organisations and agencies to try and make those links stronger between the different services and responses.
So I think the key message for commissioners of services at both national and local levels is that more specialist services are needed to tackle intimate partner violence, and these need to work really closely with mental health services. So commissioning bodies such as in the UK, the National Health Service and local authorities need to ensure that the services they commission really are multi-agency, but they're also gender sensitive, trauma-informed, and most importantly, co-produced with survivors of intimate partner violence. So I think on a practical level, this will require statutory mental health services to work closely with local specialist domestic abuse services, and therefore resources really need to be ring-fenced to support that joint working between these services, and also ensure that there are clear referral pathways between them as well. So really we need those to be established, and we need this to be in line, in the UK at least, with the NICE public health guidance that was published back in 2014 on domestic abuse and violence, that really emphasised the need for that cross-agency and multi-agency working. There also needs to be adequate funding and provision for healthcare staff to be trained in trauma-informed approaches, and specifically in the appropriate ways to assess and respond to intimate partner violence among individuals who come into contact with mental health services.
I'd like to see less wait times and an increase in access to services for perpetrators. Wait times may cost lives. The quicker we can work to change the behaviour, the quicker we can lower the risk for victims and future victims.
So when we were writing this, we really drew on the best evidence that we could find, and sometimes that, you know, involved consensus guidelines from the World Health Organization. But practitioners, when they're reading this, can really dip into how to identify, how to ask, how to respond in very simple ways. That includes the first line response. So it doesn't matter what sort of health practitioner you are, whether you're a general practitioner, primary care, through to specialist mental health services. Everybody should be able to listen, inquire about their needs, validate survivors' experience, enhance their safety, and offer support. The lives approach from the World Health Organization. So that's a good tool. And we also, though, many practitioners are also seeing people who use violence and abuse. So the ability to actually identify that and to have good referral pathways, working with multi-agency support networks, and obviously at the top of your brain about responding to someone who uses violence is that we need to keep the safety of those who are experiencing abuse, which in the main is women and children, at the forefront when you're doing this work so that we do no harm. And then the third group that is really addressed is how to respond to children and adolescents who, as we've heard, have really emotional and behavioural problems as a result of the exposure to intimate partner violence. And they need specific interventions and often that are very child-centred. So it's really drawing on the expertise, the global expertise we have, to really be able to respond to all the different family members in a way that is trauma-informed, that is co-produced with survivors, and is gender sensitive.
So I think the key messages and best practice guidance for policymakers are almost identical to those that Kelsey talked about for practitioners, because if policymakers understand that approach, then they can support the practitioners in the services that they commission. The only thing that I think, in addition, policymakers, a couple of things that policymakers really need to think about is that addressing IPV will reap huge rewards for the whole population, particularly if they realise that the impact of this kind of trauma can actually shut people down, because often women, men and children who've experienced IPV are shamed and they lack trust in services. And so if policymakers can understand that doors need to be even wider open, then I think that can help. And just to add that it's so important that policymakers must not forget about children, because if they focus on both adults and children, then that will really reap rewards for the whole population across generations. And it's also crucial to remember about structural inequalities and that certain groups in the population might be even more silenced by their experiences than others.
So just as asking about IPV is every healthcare worker's business, a sound measurement of IPV and its mental health ramifications is every researcher's and clinician's business. And we need to do much more to improve our measurement of IPV and its mental health concomitants. This was clear through the work of the Commission. We also need to advance efforts to harmonise the data on IPV and mental health that are collected, both within and across settings and within and across sectors. In measuring IPV, regardless of the setting or sector, it is also really important to strike a balance between what researchers consider to be important to measure and what survivors of intimate partner violence believe that it is important that they are asked about in terms of their emotional health and well-being. Then it's also important to include measures of IPV and both physical, sexual violence, but also other forms of IPV, such as psychological abuse and other coercive controlling behaviors in cohort studies and surveys, because knowing how to measure these different forms of IPV in studies in a way that is safe and ethical and is responsive to the needs of survivors is important. We also need to learn more about how IPV moderates the impact of the psychosocial interventions as well as the pharmacological interventions that we use to treat survivors who present with a variety of mental health problems. These data are in fact very poor, so we know little about the moderating impact on the effectiveness of interventions. We also need to learn more about mechanisms underpinning the link between IPV and common mental health outcomes like depression and anxiety and post-traumatic stress disorder. Finally, improved coordination and cooperation across sectors that are involved in research on IPV and mental health is important. We need to have closer coordination, we need to have closer collaboration, we need to have an agreed upon way in which we collect data, and that means establishing a set of core indicators and outcomes that we can apply uniformly and in a standardized way to assess the various interventions to reduce IPV.
Globally, because mental health services can be difficult to access, I think a key priority is to increase our efforts to integrate mental health care into primary health care, to strengthen the training of lay workers, and to provide grassroots and user-led alternatives to mental health services in order to prevent and reduce exposure to intimate partner violence.
A thrust of the Commission has been its emphasis on the prevention of IPV, and we know the common saying that prevention is better than cure. So preventing IPV from occurring is key to reducing the prevalence of mental health problems in society, both in high-income countries and low and middle-income countries. So research in low and middle-income countries has shown that mental health and substance abuse interventions are in fact effective in IPV prevention. These are interventions that have been delivered in low and middle income countries by lay counselors who are equipped with the skills to deliver the intervention and are supported and supervised by mental health professionals. And this is being done in low and middle income countries to mitigate the general shortage of mental health specialists. So these are really promising and innovative interventions, but they now need to be taken to scale in these settings so that we can better understand their effectiveness, safety, and the moderating factors that affect treatment outcomes in survivors of IPV who have mental health problems.
My priority is that all practitioners are not saying what's wrong with you, but are saying what's happened to you. And when they get an answer, that there is, I would call it, where is the kindness in the individual level with the patient, at the system level supporting staff who are touched by this issue, and at the organisational level. We can't do this work without there being kindness and heart across the system. It just can't be done without that.
I may not have the years of family violence training you do. I may not have a PhD, but I have lived it. I have survived it. I don't want to be viewed as someone who is damaged or traumatised. I want to be viewed as someone who has something of value and importance to contribute.
So the reason this is critically important is because all of us have met survivors who have been through fire to try and survive their experiences. I will never forget speaking to a woman who said, I'll never have double glazing in my windows because I have to hear if he's coming for me. And she was 20 years out of her situation. The pressure on her mental health still 20 years after her experience was technically over was very severe. So it's critically important that we act. The priority for me in how we do that is thinking about the whole picture, putting together that mental health and domestic abuse and wider violence and abuse picture, thinking around all members of the family and thinking about those intersecting inequalities which exaggerate somebody's situation and create further barriers. I firmly believe that we can do this. We absolutely will end domestic abuse for everyone and for good all over the world.